everyone. Welcome you all for today's webinar on Meet the Expert on recent advancement in oncology treatments 2024. With the immense pleasure, I would like to invite Dr. Deepak Dabkara, Dr. Prashant Kumar Parida, Dr. Sabina Chaudhary, and Dr. Amit Barola. So, for our first talk, Dr. Deepak Dabkara, your stage is on.
Thank you. So can you share my slides?
Sure, sir, I will share.
So
The
I will be
slides visible?
discussing. Yeah, it's visible. So thank you. I will be discussing an overview of lung cancer and the recent advancements in 2024. Next slide. So we see the burden of lung cancer in India according to the Globocan 2020 data. Next. Lung cancer is fourth most common cancer in males and overall in Indian population. Can I make this enlarge slideshow? Not visible. Thank you. So it is the fourth most common cancer. First three cancers in Indian population are breast cancer, lip cancer, and oral cavity, and cervix uteri. Fourth is lung cancer, constituting about 5.5% of all cancer cases. Next slide. It is the second most common cancer in males. Next slide. Lung is the fourth most common cancer, accounting for about 5.5% of all cases. Now we come to the investigations or staging. This includes bronchoscopy, CT scan of chest and whole abdomen, PET CT, EBUS, and endoscopic ultrasound, mediastinoscopy, and MRI brain. Next. So comparing the CT scan versus PET CT for staging of lung cancer in lung cancer stage 3, lymph nodes more than 10 mm along the short axis, they are predictor of malignancy. CT scan alone has a limited role due to low sensitivity and low specificity, and CT may help in selecting appropriate procedure for tissue sampling by seeing the images, and addition of PET to the CT scan provides the overall sensitivity of 80 to 90%. Next slide. So when is the invasive medicinal staging indicated? This is for patients who have a centrally located tumor, patients who have a tumor size of more than 3 centimeter, patients with extensive infiltration of mediastinum with no evidence of extrathoracic disease, positive nodes, yes, and bulky lymph nodes and two or on CT scan, they don't need an invasive confirmation. Discrete N2, one or two single station N2, they require a medicinal staging, and a normal medicinal on CT, but a positive on PET CT requires a medicinal staging, and a normal medicinal on CT, but negative PET doesn't require any medicinal staging. Next. So this is the same algorithm, PET CT with intrathoracic lung disease without any enlarged lymph nodes. For patients who have a medicinal lymph node negative, clinically N0 and low probability of unforeseen N2 disease doesn't require a PET CT, and patients with a medicinal lymph node negative and a clinically node positive disease or node negative disease and high probability of unforeseen N2 disease after negative PET CT will be confirmed by tissue confirmation by EBUS or EUS, and if the patients have a medicinal lymph node negative by all these procedures, they will be taken for surgery or a radical treatment, and patients who have a medicinal lymph node positive, they will go for multimodality treatment. Next slide. So evolution of therapy in lung cancer. So non-small cell lung cancer was considered as a single disease, And as of now, non-small cell lung cancer is a spectrum of disease, multiple type of lung cancer, non-small cell lung cancer, EGFR, L cross, and RET mutation, and many other mutations, PD-L1 positive tumors, and NSCLC subtype characteristics are clinically relevant for treatment planning. Next. So these are the molecular targets: KRAS, EGFR, L cross, RET, and NTRK, HER2, BRAF, PIK3CA, HRAS, NRAS, AKT mutation, MET, exon 14 skipping mutation, and many other unknown mutations. This increases the need for molecular testing in non-small cell lung cancer, and for all patients with the diagnosis of non-small cell lung cancer, there should be molecular testing at baseline. Next. And for many of these mutations, we have drugs available. Now we come to the current guidelines on neoadjuvant and adjuvant chemotherapy depending upon the disease stage and finding during surgery. So whether you use neoadjuvant or adjuvant, the benefit is nearly same, about 5% overall survival benefit. For stage 1A, without any lymph nodes, observation after surgery is the treatment. There is no proven benefit of neoadjuvant or adjuvant chemotherapy. For stage 1B and 2A, multidisciplinary team discussion is important. And adjuvant chemotherapy for high risk patients, there is no proven benefit of neoadjuvant therapy. For stage 2B, adjuvant chemotherapy is recommended, and there is no proven benefit of neoadjuvant chemotherapy. For stage 3A, 3B, neoadjuvant chemotherapy or adjuvant chemotherapy or sequential chemotherapy with radiation for N2 disease. Next. Finding at surgery and surgical resection margin affect the adjuvant treatment decision. For patients with stage 1 and 2A, complete resection, observation is the treatment, and chemotherapy for more tumors more than 4 centimeter, which are considered as high risk. For stage 2B, chemotherapy is a standard treatment after surgery. For stage 3A, 3B, chemotherapy and sequential chemotherapy followed by radiation for N2 disease. Next. Next slide. And after initial treatment, more than 50% of patients with resectable non-small cell lung cancer, they experience a recurrence within 5 years. So surgery followed by chemotherapy is the standard treatment for stage 2, stage 3. 40 to 50% patients will remain disease-free, and 50% patients will recur. The recurrence can be distant recurrence or local recurrence. Next. So for neoadjuvant and adjuvant chemotherapy, the benefit is nearly same. Sorry. So for neoadjuvant and adjuvant chemotherapy, the benefit is nearly the same. Hazard ratio 0.87 and 0.89 for neoadjuvant, 0.87 for adjuvant, 0.89. Next. Targeted therapy is now moving to the earlier stages. Adjuvant trial improves the disease-free survival seen with osimertinib in resected lung cancer. It is now also possible to further improve the survival in completely resected stage 1, stage 2, stage 3 patients. Overall, patients with completely resected, this is a Adura trial, patients with completely resected stage 1B, 2, stage 3, EGFR mutated lung cancer, exon 19 deletion or L858 mutation. They were randomized to osimertinib versus placebo post-surgery, and it was for 3 years. The study showed the overall survival advantage of osimertinib, and osimertinib post-surgery is a standard of care now. Next. Atezolizumab shows an improvement in the disease-free survival as well as overall survival in patients with PD-L1 positive patients. Next. Lung cancer radiation in 2022. So advanced technologies have led to safer treatment. IMRT has shown to improve the survival for patients with stage 3 lung cancer, stage and T3, T4 tumors, reduce dose to heart with lower rates of grade 3 or more pneumonitis, and increasing the dose to heart associated with higher risk of death in stage 3 stage 3 non-small cell lung cancer. So better technology and better survival. Next. Semantics for radiation. What is the relevance to pulmonologists? So it is important to differentiate between stereotactic body radiation therapy versus conventionally fractionated external beam radiation, which for stage 3 non-small cell lung cancer is typically IMRT technique. SBRT is high dose per fraction, typically 8 to 20 gray per fraction, 1 to 5 fractions with 3D target localization. And SBRT is used in early stage lung cancer, but due to concern for toxicity, not standardly used for large tumors more than 5 centimeter with N2 nodes. Next, 4D CT planning allows for margins around tumor to be minimized. Guided radiation therapy ensures accurate target coverage for every treatment while reducing the margins needed for tumor coverage. Adaptive radiation is creating a new radiation plan after tumor target volume have reduced in size. It allows for normal tissue sparing, and end result is a small target volume with lower doses to normal tissue, including lung, esophagus, and heart. So lesser toxicity with the currently available modalities. Next, contemporary RT techniques in stage 3 non-small cell lung cancer, long-term overall survival results from RTOG 0617 study. So it was a phase 3 RTOG 0617 study. It evaluated the standard dose versus high dose CRT plus minus cetuximab in stage 3A and 3B non-small cell lung cancer. The 5-year overall survival of 32% with high quality standard dose RT before the era of immunotherapy. There is no role of RT dose escalation, and there is no benefit of cetuximab addition. Now, even better results when immunotherapy is added to CRT backbone. And stage 3 non-small cell lung cancer is a potentially curable disease. Next. Now we come to chemotherapy with or without radiotherapy is the standard of care after complete resection in patients with stage 3 non-small cell lung cancer. For patients with stage 3 disease, the medical oncologist should work closely with the radiation oncologist and a radiologist to ensure a proper coherent approach. Some otherwise eligible patients may be unfit for chemotherapy due to factors such as very advanced age, comorbidities, or poor performance status less than 2. And not all patients will complete their prescribed course of chemotherapy. This we have already discussed stage 1, stage 2, stage 3 treatment. Next. Checkpoint inhibitors are moving to early stage unresectable non-small cell lung cancer. This is a Pacific trial, which is a randomized double-blind placebo-controlled trial, phase 3 trial of consolidation durvalumab in unresected non-small cell lung cancer. So this trial has proved patients who have received chemoradiation and have stable disease within 4 to 10 weeks. They were randomized to durvalumab versus placebo, and these patients, this trial showed the benefit of consolidation durvalumab. Next, durvalumab demonstrated 42.9% OS at 5 years compared to 15 to 25% in patients with unresectable non-small cell lung cancer historical control. Next. And emerging treatment paradigms in non-small cell lung cancer, targeted therapy, immunotherapy. Next, antibody drug conjugate. And this is the approvals for immunotherapy over time since 2015. Pembrolizumab was first approved for second line in patients with PD-L1 positive disease. Then atezolizumab for second line, pembrolizumab for first line in patients with PD-L1 TPS of more than 50, and subsequently durvalumab, pembrolizumab, non-squamous, squamous adenocarcinoma, atezolizumab, pembrolizumab in first line squamous cell carcinoma. This is how the evolution of immunotherapy in first line, second line in patients with non-small cell lung cancer. Next. What is new in non-small cell lung cancer? Antibody drug conjugates. Next. CAR T cell therapy is still not proven to be standard of care in solid tumors, but multiple trials are going on for CAR T cell therapy in solid tumors. Next. So the key takeaway is the management landscape of non-small cell lung cancer is changing rapidly. New therapies have a huge potential to improve the survival. The overall survival has improved across various subtypes and molecular alterations. The ease of oral pills over infusion in case of targeted therapy is an added advantage. And pulmonologists will play a huge role in early diagnosis. Hence, it is crucial to be in coordination with pulmonologists, and a tumor board should be held for every patient. Next. Thank you.
Thank you so much, sir. So, for our next talk, I would like to invite Dr. Prashant Parida.
Thank you, ma'am. My slides are visible.
Yes, sir.
Okay. So, my topic is biomarker, molecular biomarker testing in lung cancer. So, this is the content of my talk: lung cancer epidemiology, incidence in India, biomarker testing, evolution of biomarker test, especially past, current, and key takeaways. So, the burden of lung cancer, we'll see the Globocon 2020. Lung cancer overall, it is almost 5.5% of all the malignancies, and in men, it is almost 8%, and second most common cause in male among all the cancers. So we will see the incidence and mortality. It is almost fourth most common cause of common malignancy, incidence wise as well as mortality wise. So almost 72,510 new lung cancer patients diagnosed in 2020, out of which almost 51,000 of male lung cancer diagnosed in that. So these are the new cases, fourth most common, and mortality wise also it is the fourth most common malignant cause of death in our country. So let us talk about non-small cell lung carcinoma. It is almost 85% of all lung cancers, and out of this non-small, almost 50% of advanced non-small cell lung carcinoma have some form of biomarker positivity. Almost these are called driver mutation, and they are targetable with a FDA-approved agent on clinical trial. So these are the biomarkers. EGFR is the most common, and though it is in Western countries almost 10 to 15%, but in our country it is almost 40%. We have seen, and followed by ALK, ROS1, KRAS, EGFR exon 20, ROS1, BRAF, HOT2 new, RATE fusion, NTRK. So all these biomarkers, some of them against which we have approved agent, and against some of the biomarkers now the clinical trial are going on. So probably in future we'll have more number of these targetable therapies. What is the importance of this biomarker testing? And because it has been seen by several studies, patients with identifiable actionable mutation who received a targeted therapy, they have better long-term survival, and the median OS in this analysis, you can see almost 18.6 months versus those who have no targeted therapy or no actionable biomarker, they have 11 months. So there is a significant improvement in survival, those having a targetable driver mutation. And so that is the reason why most of the guidelines now recommend testing all these biomarkers, EGFR, ALK, BRAF, MET, RATE, NTRK, RAS, and PDL1. So almost every guidelines, including ASCO, and ESMO, they have recommend testing all these biomarkers. So what are the methods? Either we can test by tissue, taking from tissue, or by body fluids. We call it as liquid biopsy. So what are the methods of tissue testing methods? Either DNA sequencing by NGS or PCR, RNA sequencing panel, or IHC or FISH. So DNA sequencing, especially by NGS, the insertion point mutation and VRAF2 and MET. Similarly, in the RNA sequencing, mainly specific for fusion abnormalities in ALK, ROS1, RATE, and NTRK. And FISH, it detects ALK, ROS1 more specifically, and though it takes some time, but can be faster. Whereas IHC is an alternative for this ALK and ROS, which this IHC is an easy test. It is faster than FISH, but sometimes it is not reliable or sensitive enough to guide the treatment. So we can replace that if someone come with IHC positive for fish. And PD-L1 is tested by IHC only. So the evolution of these biomarkers in NLC, so the journey from tissue extraction after diagnosis either can be this tissue or biopsy. Specimen can be collected by resection, excision, or small tissue biopsies, or by cytology, where cells shed from body surface like urine fluid, urine fluid, sputum, cerebrospinal fluid, or other body fluids, where cell blocks can be prepared, or from tissue, fresh frozen block can be prepared. And if technically not feasible or some 12%, we have an option of liquid biopsies on blood or body fluid. And after that, morphologic assessment based upon histology, cytology, and then DNA or RNA or protein extraction and molecular analysis usually done by this flow method. So biopsy is key for diagnosis, histologic subtype, and biomarker testing. So histologic subtype, previously we are treating when especially with chemotherapies based upon whether squamous, non-squamous, adenocarcinoma, large cell. But nowadays, biomarker is more important, and this biomarker testing is equally suitable from primary and metastatic lesion. But bone biopsy usually should be avoided due to decalcification and degradation of DNA, and liquid biopsy and an alternative option those who where technically it is not feasible or frail patients. So always test for all these biomarkers against which we have approved agents. So these are EGFR, Alcross, BRAF, NTR, Meritaxon 14, PD-L1, and always try to use a broad NGS panel. And this is for adenocarcinoma, for squamous cell carcinoma. Consider testing for all these biomarkers in young neighbor or light marker, or if biospecimen is mixed histology, and test PD-L1 in all the non-small cell lung carcinoma, including squamous and adenocarcinoma, and all these testings should be completed within 10 to 14 working days. Now coming to liquid biopsy. So liquid biopsy usually helps in diagnosis and treatment selection, monitoring and monitoring prognosis, response to treatment, and progression or relapse of the disease. And sometimes ctDNA testing overcomes some major challenges as with tissue testing, especially minimal invasive for patients allowing serial biopsy, and it takes care of the heterogeneity and tumor changes over time. So though ctDNA testing may never replace tissue biopsy entirely, but could have a complementary role to support treatment selection patients with advanced non-small cell lung carcinoma. So what is the role of the ctDNA in early stage or resectable non-small cell lung carcinoma? Because we have seen MRD, minimal residual tissue disease, has been associated, MRD positive associated with poor prognosis or relapse in liquid and some of the solid malignancies. So in resectable non-small cell lung carcinoma or early stage lung carcinoma, presence of MRD may predict disease recurrence. So one of the trial, the PRESSURE study, where 24 early resectable non-small cell lung carcinoma patients followed longitudinally after resection, and they have phylogenetically ctDNA testing was done, and it has been seen that 93% of patients, almost 13 out of 14 patients with disease recurrence were MRD positive. Similarly, 90%, that means 9 out of 10 without recurrence were MRD negative. So in this study, ctDNA profiling was able to confirm MRD negative and detect MRD in patients who relapsed before their disease was picked up by standard event. So this is a new concept, especially after resection in early stage lung carcinoma. We can predict the recurrence or relapse by testing ctDNA or MRD. So the comparison between tissue and liquid, there are a lot of similarities, difference also. The sample acquisition is difficult or challenging in tissue, whereas it is easier in liquid biopsy. Repeat sampling, serial testing challenging with variable biopsy in tissue extraction, whereas in liquid biopsy, minimal invasive procedure allowing for easy serial testing. Biopsy correlation with histology and cellular phenotype possible in tissue, whereas it is difficult direct correlation between ctDNA results, histology, etc. Not possible. Sensitivity is very high in liquid biopsy. The sensitivity level, you can say ctDNA may comprise less than 1%. It is very sensitive. But in the tissue, lower tumor cell content acceptable with sensitivity 1 to 10%. Analytical standardization uses existing validated tissue processing and handling procedure in the tissue, whereas standard for analytic performance character of liquid or ctDNA have not been established. So whether multiple genes or single gene testing, you can see this flow chart. By doing single gene testing, it takes a lot of time, cost also, whereas during that process you may exhaust the tissue, so you may not able to test all these biomarkers. Whereas in multi-gene assay or a next by NGS, we can test all these biomarkers by a single testing. So limit excluding the time constraint. So nowadays, next generation sequencing by a broad molecular panel has been preferred over the single gene testing. What are the advantages of NGS as the number of clinically actionable biomarkers is increasing day by day. So the ability to evaluate all these biomarkers in a single gene testing, and there is several advantages of NGS over all these single gene testing. So if one or few molecular biomarkers are needed, then the cost will be high and long turnaround time in NGS. But in multiple or many molecular markers are needed, it can reduce cost, shorten turnaround time, and lower tissue requirement. Also, it is an advantage. So by doing NGS, there are several advantages. Detect a broad range of molecular in a single test, and sometimes you pick up the newer additional treatment option for newer markers which have been picked up by the NGS. But it requires experienced personnel. So these are the cons of NGS. Advancement in the field of NGS are still evolving. So these are the techniques used frequently for mutation detection, single node variants or CNVs, and these are the methods of testing all these biomarkers and targeted therapy. We'll discuss in detail. Now coming to the EGFR mutation. So EGFR mutation is the most common actionable biomarker, especially in our country and East Asian region. This can be tested by FFP sections, press or frozen or alcohol-free specimen, or sometimes PCR-based assays. Cytology samples are also suitable, but cell blocks should be prepared. And it has been seen that the tissue from primary as well as metastatic sites, the discordance rate between the EGFR mutation and primary tumors and corresponding metastatic sites are rare. So the EGFR testing can be done tissue from both primary as well as metastatic site. EGFR mutation in early lung cancer. So nowadays, EGFR testing should be done in early stage lung cancer, because after stage 1B, those having EGFR positively, so after chemotherapy completion, we have an option of using EGFR TKI like osimertinib as adjuvant therapy as seen in ADAURA trial. Similarly, ALK testing, ALINA trial also show advantage of alectinib, and PD-L1 testing. At least these three biomarkers, EGFR, ALK, and PD-L1 should be done in resectable lung cancer also. So advantage of NGS over PCR, because few PCR misses sometimes few mutations which are picked up by NGS, and one study shows that 48.6% of EGFR exon 20 insertion mutation identified by NGS are missed by PCR, and out of 17 most common this exon 20 mutation variants, only 4 can be identified by PCR. Now coming to the ALK rearrangement. So this table shows ALK correlation between ALK IHC and ALK is encased by both technique for current and published, and it has been seen that there is a high concordance rate and the IHC and FIS, and false positivity rate of 0.1% with FIS. And as IHC is less expensive, hence more widely adopted. There is a high concordance rate. So IC can be used instead of this. ROS1, this is the algorithm of all ROS1 testing after diagnosis of adenocarcinoma or non-small cell lung carcinoma. ROS1 can be tested by IHC or FISH. If IHC is ROS1 positive, it can be reconfirmed by a second method like FISH, or you have done FISH which come out to be positive, you can reconfirm by IHC or another molecular. So, but detection of elevated ROS1 protein level by IHC may provide cost-effective screening prior to confirmation by FISH testing. So, because IHC is easy and cost-effective, it can be used as screening method, and you can reflexively test for this in those patients. So now coming to KRAS, this KRAS or RAS sends activity signals to number of cellular pathways downstream. The EGFR, RAF make ERK pathway leading to cell proliferation and survival. And these KRAS mutations are mutually exclusive with EGFR and RAF. And almost 30% lung carcinoma, adenocarcinoma will have this KRAS mutation, and the most common of these are codon 1213, and G12C variant is the most common in 13% of patients, and it predicts poor prognosis. The method of detection, multi-gene NGS panel is preferred, and single-gene KRAS G2 testing is not currently recommended and should be performed only by a multi-gene panel. The targeted therapy options, sotorasib is currently FDA approved for patients with G12C mutation, and adagrasib, another molecule, have showed potential in early phase 2, phase 3 trial, and the exact mechanism of resistance not well understood yet. Whereas BRAF, another downstream signal molecular pathway, and this RAF kinase involved in regulating cell proliferation survival. BRAF is 600E mutation. This variant mutation is present in more than 50% of the mutation cases, and non-BC0 mutations such as 600K, 466B, and 469A are less prevalent, seen in 15% of BRAF mutation, and overall it is almost 1 to 5% patient of non-small cell lung carcinoma. And method of detection, though IHC and PCR generally accepted but not widely recommended. NGS is generally used for multigeneous, and BRAF mutation is usually treated with BRAF inhibitor in addition to MEK inhibitor, because this MEK inhibitor can block one possible resistance pathway. So dabrafenib plus trametinib is the MEK inhibitor, and the impact of BRAF mutation can therapy selection is not also well understood, and the resistance mechanism usually by redirection of cell signaling by downstream MEK or MEK1 or MEK2 kinase. Therefore, trametinib is added to prevent this resistance. CMET, MET exon 14 skipping mutation. This CMET has a normal role in embryogenesis and wound healing, seen in 3 to 4% of non-squamous NSCLC, 20 to 30% of sarcomatous cancer. So if you find a sarcomatous non-small cell lung carcinoma, you should or you must do this CMET or MET exon 14 mutation, because majority of MET 14 exon skipping mutation can be detected by DNA NGS, but in increased sensitivity with RNA NGS. So RNA NGS is more sensitive than DNA NGS. And these are the testing methods. Usually IHC is not recommended. NGS is the preferred, though PCR can be done, but it is design dependent. RNA most sensitive, RNA NGS, and though DNA and NGS can be done, but these are design dependent, potentially detect many mutations. So NGS mutation is most sensitive and preferred. Similarly, rate receptor, normal run in neural genitorenal development, 1 to 2% in non-squamous cell lung carcinoma, but it's in papillary thyroid carcinoma 10 to 20%, and this majority rate fusion can be detected by DNA NGS, similar to MET. It is more sensitive in RNA NGS. These are the methods. IHC is significant false negative, so not preferred. Usually NGS is preferred. RNA NGS, majority of rate fusion can be detected with DNA NGS, but increase sensitivity with RNA NGS. NTRK options of testing IHC, RNA or DNA NGS, these are RT-PCR. So all these methods have advantages and disadvantages, but RNA NGS most sensitive, but IHC widely available, and it has a faster turnaround time. So replacing to NGS versus ISC is a reasonable option for NSL due to low prevalence of these NTRK fusions and important to qualify negative results, limitation of samples for testing. So this is the ESMO working group recommendation for potential approach for NTRK testing. NTRK testing, if desired, is the histologic tumor type known for to harbor high recurrent for NTRK, and if more likely or highly likely to have this mutation, you can directly go for FISH or RNA NGS. Whereas if this there is less likely, then you can go for other method. And if sequencing is platform available, then you can directly go for NGS, and you can reflexively test with IHC. And if there is no suitable, these are the methods: NGS, IHC. The advantage of IHC, it is rapid and detects, transcribed, translated event only, low cost, widely available, where NGS potential multiplex testing, less depletion, user pattern position are defined, RNA injection is more sensitive, and disadvantage of IH is depletion of tissue fusion pattern unknown, less widely validated, whereas the disadvantage of NGS is longer wait time and cost is also high. So replacing NGS versus IH and reasonable option for these NTRK fusion because due to low prevalence. Ortho mutation or ERBB2 present in 3 to 5%, mostly exon 20 inframe insertion, mutually exclusive to other mutation, and usually seen in never smokers. So just like EGFR, it is seen in never smoker, but it has worse overall survival than other subtype lung cancer. And in non-small cell lung carcinoma, this mutation amplification must be identified using NGS DNA panel, similar to breast cancer. And this is the algorithm for biomarker positive advanced non-small cell lung carcinoma. So if you will get a actionable biomarker, instead of starting chemotherapy, you should start with a targeted therapy against the biomarker positivity. So yes, except in exon 20 insertion and KRAS G12C, where amivantamab and sotorasib respectively should be started in the second line. Otherwise, in the AGFR, we have almost 5 targeted agents like osimertinib, alectinib, apatinib, gefitinib, dacomitinib, and ALK, alectinib, brigatinib, lorlatinib, ceritinib, or crizotinib, and ROS1, crizotinib, or entrectinib, BRAF, dabrafenib, trametinib. As we have already discussed, all these targeted agents against the biomarkers should be started instead of chemotherapy. Now coming to PDL1. So these are the few immune checkpoint inhibitors. Four important or frontline immune checkpoint inhibitors: pembrolizumab with their companion diagnostic test like in pembrolizumab 22C3, and the complementary test durvalumab SP263, atezolizumab Ventana SP142, and nivolumab DACO 288 complementary. So these are the companion and complementary diagnostic tests should be, or platform should be used, and a different scoring system is adopted depending on the antibody used and the biomarkers for immunotherapy or immune checkpoint interval. Though it is controversial, PDL1 is the sole current biomarker able to guide immunotherapy, though it is not a perfect or suitable biomarker. There are several imperfect about this PDL1 because it has been seen that most only commonly when added to chemotherapy, possibly some due to synergistic effect of chemotherapy and PD-1 inhibitor. Tumor mutation burden (TMB), though initially it was used in non-small cell lung carcinoma, but not currently used because conflicting correlation with survival in several segments trials. MSI high, though it has been seen to guide immune checkpoint inhibitor in few malignancies like colorectal or endometrial, but not relevant in lung cancer. They are actually possibly related to resistance to immunotherapy, and it is being studied. So key takeaways from my talk: biomarker testing in non-small cell lung carcinoma has evolved from single gene to multiplex testing by NGS, multidisciplinary meeting help in better understanding of sample and tissue requirements. Sample could contain adequate tumor content at 10% to prevent delay in processing, and ideal turnaround time is 10 working days or 2 weeks, and high throughput platforms such as NGS can be used to screen several genes at a time to provide results within the estimated turnaround time. Thank you for
Thank you so much, sir. So, for our next talk, I would like to invite Dr. Sabina Chaudhary.
Hi, good evening. Can I have the slides, please?
Sure, ma'am, I will share.
Oh, good evening. I'm Dr. Sabina, consultant in Rajiv Gandhi Hospital, Delhi. So I'll be talking basically on the ADORA trial, that is the adjuvant treatment for EGFR positive early lung cancers, resectable patients. Next slide. So, as we know, the survival outcomes in resectable non-small cell cancers still needs to be improved. So, around 50, if we take an average, around 50% patients recur either locally or in distant metastasis. So, as we go higher in the stage, like in stage 1B, it is around 65 to 75% 5-year OS. And as we move on to stage 3A, the survival rates around 30 to 45%. So, there is an unmet need that needs to be solved or resolved in resectable lung cancers also. Next slide. So this is the basic recommendations that we follow these days for early lung cancers. Any patient with a non-metastatic resectable lung cancer, we need to do an EGFR based on the trial I'll be talking about, and a PDL1. So also now we do ALK also in our institute, based on the ALINA trial. So if the patient is now, depending on whether the patient is EGFR mutation positive or EGFR negative with PDL1 positivity or negativity, we follow the approved treatment recommendations. Next slide, please. So there was a study which was presented in ASCO 2023, which mainly predominantly patients with stage 1A to 3B non-squamous non-small cell lung cancers were enrolled. And it involved mainly the Middle East, African, Latin American, and Asian countries, in which they found that EGFR mutation prevalence was around 50%. So in which DEL19 was most common, which was followed by L858R. Next slide, please. So in this, basically, they found out that even after surgery, so if we see surgery, many patients are not receiving any systemic therapy. Around 50% patients have received an adjuvant systemic therapy, either in the form of radiation or chemotherapy. Next slide. Next slide, please. So this is basically to highlight that despite adjuvant treatment, which involves either surgery or which involves either chemotherapy or radiation, still around 50 to 60% patients either they recur locally or they recur distantly. So this is what they found out in the study. So there is definitely an unmet need for improved neoadjuvant strategies or adjuvant treatment options that we need to improve the outcomes in resectable lung cancers also. Next slide, please. Okay, so this was the ANITAS trial, which is a landmark study, which found out that, which was basically in which they found that by giving adjuvant systemic therapy, systemic chemotherapy, we improve the overall and the disease-free survival at 5 years. It is around 5% absolute benefit of giving chemotherapy in such patients. That is for stage 1B to 3A. So all the patients that is resectable and they are in category stage 1B to 3A, they need adjuvant systemic therapy, because of which you can improve the OS benefit by 5% at 5 years. Next slide. Next slide, please. Okay, so using EGFR TKI is not a new thing. There have been many trials which have been tried on geftinib or lotinib. So all those trials in those that after surgery, they have tried giving a TKI in the form of geftinib or lotinib, but still what they found was there was a meaningful DFS improvement, but they have not been translated into an OS benefit. So the reasons can be anything. It can be maybe the design trial study, or it can be like less penetration, maybe the blood-brain barrier. These drugs do not penetrate the blood-brain barrier. So next slide, please. Next slide. Yeah, so there was a meta-analysis which was done, which included all those trials which were done on geftinib and erlotinib as adjuvant strategies in EGFR mutant non-small cell lung cancers. So they found there is a DFS benefit. So there's a 48% reduction in the risk of disease recurrence. However, OS benefit was not yet found. Next slide. So why have these data not yet resulted in a change in clinical practice? Mainly because there has been no OS benefit till date. Next slide. So then now we come on to the main study, ADORA trial, which was a landmark study which was presented in ASCO 2023. It was a practice-changing study about osimertinib. So we have been using osimertinib very much now in metastatic non-small lung cancer. So till now we had a DFS data for osimertinib in the adjuvant setting, but now we have an impressive OS data also for osimertinib. So ADORA trial, just talking about the study design, it was done on patients with completely resected stage 1B to 3A. And these patients would have, I mean, with or without adjuvant chemotherapy, both the patients were included. So they were stratified. Basically, there was a primary endpoint which was taken DFS into consideration in stage 2 to 3A. Whereas in the secondary endpoints, we had DFS in the overall population, which also included stage 1B. And then OS was a secondary endpoint, and of course, health-related quality of life and safety concerns were there. So that was in the secondary endpoint. And in this, the patients were given either a placebo or osimertinib in the dose of 80 mg once daily for 3 years. And this treatment was continued till they had a disease recurrence or a treatment completion, like for 3 years, or if any discontinuation criteria was met. Next slide, please. Okay, so as we can see, the primary endpoint, which was a DFS, it was improved in both the primary population that I told was stage 2 to 3A and the overall population, which also included the stage 1B. So in this, as you can see, median DFS is significantly better in osimertinib arm, which is around 65.8% as compared to the placebo arm, which is 21.9% with a hazard ratio of 0.23. And in the overall population also, with osimertinib, it is 65, and with placebo, it is 28.1%. So there was a significant benefit in the DFS in the ADORA trial. Next slide, please. So this was also an endpoint, CNS disease-free survival. Now, as we all are very well aware from our metastatic studies, that osimertinib has a very good blood-brain barrier penetration. So adjuvant osimertinib also demonstrated a CNS DFS benefit versus placebo in both the primary population of stage 2 to 3A and also in 1B to 3A. So this was the ADORA updated CNS DFS. It is not reached till date. Next slide, please. And as per the safety analysis also, there were no new adverse events were noted when compared to the primary readout of the ADORA data, which was this. Next slide, please. So, and I think this OS slide is not there, but OS data also, there's a hazard ratio of around 0.49, which is very impressive. So in order to improve the survival, we need to put more efforts to identify lung cancer early. We are regularly doing in our institute for all patients who are resectable. We do EGFR in those patients, and we have started giving patients osimertinib after surgery also for EGFR mutant patients. So, and it should always be a multidisciplinary, that is a teamwork, and patients may, that's all. Thank you. Next slide, please. Yes. Yes. Yeah. That is a concluding slide. So probably. Next slide, please. That's. So I think ADORA trial has given us a significant benefit of giving osimertinib in metastatic non-small cell lung cancers, which are EGFR mutant patients. Thank you.
Thank you so much, ma'am. So for our last talk, I would like to invite Dr. Amit Badola.
Hi, can you give me the right of sharing screen because I'm not able to do that?
Sure, sir, please.
I think now it's visible.
Yes.
Right. Sorry. Hi, good evening, everyone. So my talk will be this targeted therapy in non-small cell lung cancer in advanced setting. We have already discussed the epidemiology of lung cancer, and we know that it is the most common cancer in terms of mortality worldwide, while in terms of incidence, it's ranked second. If we'll talk about Indian Globocon data, it's the fourth leading cause of death in India. And this is really important. We know that majority of the patients which we see in our OPD are stage 3 or stage 4 patients. And if we compare the survival in later on stages, it is less compared to early stage where we are seeing the 5-year OS is approximately touching 90%. And for the stage 4, it was 10%, the 5-year OS data. Now with evidence of new technology, we have for the more than 50% of the non-small cell lung cancer, we have the biomarkers where we can target these certain mutations or overexpression with our new targetable therapies. So we know that we have KRAS, EGFR, ALK, HER2, BRAF, RET, MET. There are plenty of lists where we have a targetable mutation and for which we have a specific drugs as well. Some of them are actually a predictive biomarker and some are the prognostic biomarkers. If we see the testing methodology, we are actually using more or less NGS for all patients. But if we want to see separately these mutations for EGFR, we know that we have to do a PCR-based testing. For ALK and Roche, we can do ISC, but for Roche, ISC is only for screening. We have to confirm our result by FISH. All these, both fusion, we can check on FISH also. And PDL1, we know that we have ISC, different platforms for like DACO22C3 for Pambro or SP263 for Durva. If we see the EGFR driver mutation, which we are going to talk in our next slides, we know that it's mostly seen in exon 18, 19, 20, and 21. And the most TKI sensitive mutation are exon 19 deletion or exon 21 point mutation, which constitute almost 90% of these mutations. And if we see this prevalence of these mutations, it's actually similar in all across the stages. It's almost 30. In Asian, it is quite high compared to Caucasian, where it is 10 to 20, while in Asian female, it's like 30, 40. And when we were doing our residency 4 or 5 years back, our old professor used to say that if the non-smoker Asian female, we were actually not doing these EGFR testing. We were just empirically giving first generation TKI to those patients, but not anymore now. And 5 or 6 years back, these testing was only limited to the advanced stage disease. But now these testing are actually very important in to decide the treatment in early stage lung cancer. That's why these recommendations are now for early stage lung cancer also to test all these targetable mutations. If we talk about third generation EGFR TKI, osimertinib, it is a beautiful drug. It's having a blood-brain penetration. It is irreversibly bind to these EGFR receptor. Compared to the side effect profile, it's much safer compared to the first and second generation TKI. and it is also effective in the resistant mutation of EGFR T790M. This flora, it's not like we all actually know this. The game-changing trial, the third generation osimertinib, which was compared with the first generation TKI. This flora, the main endpoint was PFS. The secondary endpoint was overall survival. And the important thing is the crossover was allowed in this trial. Both arms was well balanced in this trial, and they have taken the EGFR TKI sensitive mutation, exon 19 deletion, and exon 21 L858R mutation. And if we see that this PFS is 19 months, approximately 19 months, compared to 10 months with the first generation of TKI, with a hazard ratio of 0.46. And the effect was seen in across the subgroup, whether it is whether the CNS disease present or not, whatever the mutation was, exon 19 or L858R, the benefit was seen in all subgroups. And if we see the objective response rate, the duration of response was for approximately 1.5 years in third generation TKI arm. And it was the first time when we saw that one TKI compared to the another TKI showed, despite crossover, overall survival benefit. And the overall survival in a stage 4 lung cancer, no chemotherapy, and the survival was 38 months compared to 31 months with first generation TKI. And as I told earlier, it is very well tolerated drug. The side effects which we see with the first and second generation TKI, it's very less compared to third generation TKI. If we see the rash and acne, which is approximately 80% in first generation TKI, it's almost 60%. And if we see the grade 3 and grade 4, it's almost 1%. We know that these TKI are actually very notorious for the skin toxicity, and many times we see our patients developing these toxicity. We hardly see with osimertinib all these toxicities. So summarizing flora, we know that it showed not only PFS but also showed the overall survival benefit. It is having this blood-brain penetration. If you see this CNS activity, we all know that if the patient carries disease in the brain, the prognosis is poor. So if we see in those subgroup also, the PFS is approximately 16 months compared to the standard of care, which is around 9 months. While without CNS metastasis, as we saw, it's approximately 19 months. If we compare this third generation TKI with the second generation TKI, dacomitinib, the PFS, if you say numerically, dacomitinib is giving you a median PFS of 14 months, while osimertinib is giving a PFS of 19 months. But the most important thing, if we compare this Archer trial with the flora, your graphs start separating immediately in the flora, which is really important. So if we see in the Archer, we are losing approximately 25% of the patient in a first 6 months, while with flora, it's almost 95. So that is the most important, that we are giving a drug which is highly effective and we are not losing patient early. And this Archer was also not statistically designed for proving the overall survival benefit, though it showed that numerically the OS was 41. Well, as we discussed in Flora, it was the first trial when we saw that any TKI is giving us an OS benefit. And at 3 years, 54% of the patients were alive, as we discussed in the stage 4 non-small cell lung cancer, where 5-year overall survival is approximately 10%. This subgroup, specifically EGFR, ALK, they are showing very good overall survival with all this TKI without chemotherapy. If we compare with osimertinib with another second generation TKI, afatinib, it is not showing. Afatinib is failure compared to if you compare with osimertinib. This is I talk if the safety profile osimertinib is very, very well tolerated drug compared to second generation TKI, where we know that we have to reduce the doses every time. And the drug discontinuation rate due to toxicity is approximately 40-45%. This is important. The FLORA is not only the upfront study, it is also a sequential study where we see if the patient is started with the first generation TKI, if they progress, we know that the most common cause is T790M mutation. In those patients also, this third generation TKI is effective. But if we see, if we are using this effective drug earlier, the results are better. As we see, we are actually 30% patient. If we start patient on first generation TKI, 30% patient where we could give a potential treatment upfront, we are losing those patients because they are not getting any second line of therapy due to any reason. So that's why they are the author and the other school of thought is that we should give the potential treatment upfront, because we also don't know whether this patient will develop. We know that almost 50 to 60% patient will develop T790M resistant mutation, but we can't really predict it. So that is important. We have to start with a potential treatment upfront. This is the same thing, as I told you, 30% of the patient in the competitor arm in this FLORA trial couldn't receive the second line treatment, which lead to the attrition. And if we compare in the second line, 47 patient received osimertinib, and despite that, we saw overall survival benefit. So that means, like in second line therapy, almost a second patient received third generation TKI, but despite that, there's overall survival advantage. And due to all this, we know that it's a category 1 evidence in all patients. And now with the FLORA 2, with chemotherapy also, the PFS is reaching up to 30 months, which is great news for our patients. So concluding all this thing, we know that the first time where any EGFR TKI translated into the overall survival benefit despite the crossover. The PFS with osimertinib alone is approximately 19 months. But as I told you, with when we added chemotherapy with osimertinib, which is well tolerated and we are using in our clinical practice, this is actually we are gaining 10 more months progression free. We know that osimertinib is crossing the blood-brain penetration, is crossing the blood-brain, and that's why there's a reduced chances of CNS progression and a good CNS progression-free survival as well. So we know that osimertinib, whether to use with chemotherapy or alone, it is a standard of treatment in EGFR positive mutant non-small cell lung cancer. So thank you.
Thank you so much, sir, for your talk. Thank you everyone for joining today's webinar. We'll meet again. Good night. Technical team, please close the meeting.
Okay, ma'am. Thank you.